Welcome to NurseEdScholar. Now we're going on lesson 2, and we're going to talk about acute coronary syndrome. So when you hear that term, acute coronary syndrome, what do you actually think? I mean, are you thinking ST elevation, troponin, MONA, or do I have to get a 12 lead ECG? Okay, but let me ask you something that's even more important. If a patient is having chest pain right now, what is actually life threatening? Okay, because the NCLEX is not actually testing you, you know, if you can label what a STEMI is. It's actually testing whether you can recognize when perfusion is failing and what do you do next. So today we're going to simplify acute coronary syndrome, the way the exam actually tests it. Okay, all righty. So what does it mean? Acute coronary syndrome. Well, it actually means that the heart muscle is not getting enough oxygen. And that's it. It's an oxygen delivery problem. It's not a rhythm strip memorization problem. It's not a terminology problem. It is a perfusion problem. And when the coronary arteries are blocked or narrowed because of plaque buildup in the coronary arteries, they rupture and cause a clot. So you have blocked because of the buildup of plaque, or they can be narrowed and blocked. Well, blocked because of a clot, and then narrowed or blocked because of the buildup of plaque. And when that happens, oxygen decreases, the heart muscle becomes ischemic, and if it's prolonged, the cardiac tissue dies. But the question is not on the NCLEX, is this a STEMI or a non-STEMI? The question really is the patient stable or deteriorating? The NCLEX wants you to see that acute coronary syndrome becomes life-threatening when perfusion to the heart causes systemic instability. That's what the NCLEX is seeing if you can recognize. Now, understand that not all chest pain is immediately fatal. Okay. Life threatening acute coronary syndrome looks like your patient has hypotension. They'll have intense diaphoresis, altered mental status, severe crushing chest pain. They may exhibit signs of shock, which would be cool and clammy skin, decreased urinary output. You may see ventricular dysrhythmias like ventricular tachycardia or fibrillation. And the patient may have some nausea and vomiting. You see, if the heart can't pump effectively, which is called heart failure, and since the heart is no longer able to pump, it leads to reduced flow and congestion in the veins. So when that happens, the blood pressure drops, perfusion to the brain decreases, the kidneys start to shut down. And this is where priority shifts from a diagnosis to stabilization. Now, let's look at stable versus unstable chest pain. So, you have two patients. Patient A has some mild chest pain, their blood pressure is 132 over 84, and they're alert. Now, your second patient, they also have chest pain, but their blood pressure is 82 over 50. They're having cool and clammy skin, and they're confused. So, of course, your second patient is deemed unstable. The diagnosis is actually secondary. The diagnosis of chest pain is secondary. You have to look at the patient's presentation. Now, if you haven't heard, you'll hear an acronym called MONA. And MONA, actually it means morphine, oxygen, nitroglycerin, and aspirin. And so in school, they'll have you memorize this acronym. But don't let that fool you. They'll say, first you do morphine, you give oxygen, you give nitroglycerin, you give aspirin. But the NCLEX doesn't want you to just memorize that. They want you to critically think. They want you to be able to understand when to apply it. So, for example, if your patient is hypotensive, so let's just say their blood pressure is 82 over 50. If you give that person nitroglycerin, you're going to drop that blood pressure. You're going to make that hypotension actually worse. And you definitely don't want to do that. And if the patient is bradycardic, You don't want to give them morphine because that's going to worsen the instability. And so the NCLEX is going to test to see if you can recognize that. Recognize that just because there's an order, do you know when to act on those interventions? Okay. So going into that, the NCLEX does have some traps. They want to know if you can perform a safe action. So if you administer that nitroglycerin before assessing the blood pressure, like I said before, you're going to lower that blood pressure. You're going to make that hypotension worse, and you're going to worsen your patient. And also, students tend to, when they see a question, they'll see, oh my goodness, the patient has chest pain. So I have to treat the pain. But you have to assess your patient first. You're going to have to ask, what's the blood pressure? What's the heart rate? Is perfusion adequate? Is the oxygen compromised? Because before you want to give a medicine, you need to assess the patient to see if they can even handle the medicine that you're about to give them. Because you definitely don't want to make your patient's condition worse. Now, when you look at troponin in your ECG, or you may also see it as EKG, troponin indicates myocardial injury. But the NCLEX is rarely asking you, what is troponin? It's really asking, what do you do with this information? The doctor orders the blood test and the troponin numbers come back. Because if the troponin is elevated, but the patient is stable, you monitor, you notify of, the results of the blood test. But if the troponin is as elevated, but the patient is hypotensive, you prioritize perfusion and you escalate care. And that's what they're asking you. Sometimes your patients may have an elevated troponin, but it doesn't. But if everything else shows that the patient is stable, you're going to monitor. Like I said, you're going to notify the provider, but you may not have to act on anything at that moment. You know, understand that you don't have to, memorize every ST variation. But you do need to recognize if it's new. If there is new ST elevation, if there is ventricular tachycardia, if there is ventricular fibrillation, excuse me, if there is symptomatic bradycardia, you need to ask, is the patient perfusing? Because if not, that is an emergency. So let's look at this fourth step, I guess, acute coronary syndrome framework. And I've been hinting at that this entire time. When you're faced with an ACS question, first you need to say, I'm going to assess stability. What's the blood pressure? Is the level of conscious, normal? Are they alert and oriented? How is their skin? How's the urine output? The second step is you need to evaluate perfusion. Is their skin cool and clammy? Do they have bradycardia, a decreased urinary output, an altered mental status, hypotension? Because all of those are signs of shock. Also when you're evaluating perfusion, are there signs of heart failure? Is there hypotension, an altered mental status, or decreased urine output? The third step is you're looking at your orders. You're going to review medication safety. So if you see an order for nitroglycerin, is the patient hypotensive and will this worsen it? Yes. Is oxygen needed? What's their O2 sat? Um, do the patient have, EKG monitoring in place? So you need to make sure that you assess all of those things. And number four, you want to choose the action that prevents deterioration. So, remember, the NCLEX is not asking you, to move quickly. They want you to pick the safest action. And that's how they're going to tell if you're going to be a safe and competent nurse. So let's look at a quick, just mini scenario. So you have a patient and your patient comes in with crushing chest pain. And that should be a heads up. But then on top, they have a blood pressure of 84 over 48. They have a heart rate of 118. They have cool and clammy skin. And then you look at the chart and there is an order for nitroglycerin sublingual. So what would you do? Well, I hope you hold the nitro, okay? Because you're going to bottom out that patient's blood pressure that is already low, and you're going to cause serious damage to your patient. And you're going to have to notify your doctor or provider ASAP. Because giving nitroglycerin, like I said, can cause cardiovascular collapse. I understand that, a lot of students say, well, the patient's in pain, the patient's in pain. The human body can endure pain. We want to treat it, but if the patient is, unstable, the nitroglycerin will cause severe hypotension, you know, and that's going to be dangerous to your patient. So understand the patient has chest pain, but if you give a medication that causes cardiovascular collapse, you're doing more harm to your patient than the chest pain will. And I just want you to understand that. Students always go to, I want to treat the chest pain, and they forget everything else in the stem of the question. You have to pick the safest action. And maybe there is something else. Maybe that patient needs to go straight to the cath lab. But if you give them that nitroglycerin or you give them some morphine if they're bradycardic, you're going to do more damage, than if the patient has some chest pain and you rush them over to the cath lab and they open up those arteries. You're doing your patient so much, you're going to actually do better for your patient to hurry up and call the rapid response. Okay. And that's really what the take home is on this video. So hopefully, this gave you a simplified version of acute coronary syndrome. And I hope you can think of it a little differently now. If you noticed in the video, I kind of repeated things over and over again because that is what it is. We talked about the signs, we talked about the symptoms, we talked about medications and the best time when to hold those medications and when to call the rapid response. So if you like it, please like the video. Please subscribe to NurseEdScholar. Download the workbook. I'm developing resources that you can use for studying. And in the next lesson, we're going to talk about heart failure and the priorities that you would be considering, and why fluid versus perfusion. Thinking kind of changes everything. You're thinking about the fluid in your patient, but then you also have to think about perfusion. So we're going to talk about that. So all of this, like I've said before, is to help you study smarter so you can test like a pro. And remember, think perfusion first. Until next time, thank you for watching from NurseEdScholar.